Dear Hermann, thank you very much for the introduction. As you can see on the first slide, this is at least in part a cooperation work of 4 sites, of which 3 are present here with Ralph and Jacob and Nikos Werner from Bonn. But what am I going to talk about? First of all, some experience that we have made recently and that we have also published as a kind of a standardized approach to the AMI cardiogenic shock patient. And just to go over that more quickly so you can have a read on it, is basically an algorithm that we established for primarily out-of-hospital cardiac arrest patients. It was recently published in Czech Cardiovascular Intervention. And when we realized that of our cardiogenic shock patients, 2/3 had been resuscitated before hospital admission, we actually adopted this algorithm that was primarily for out-of-hospital cardiac arrest patients to be relevant for cardiac arrest and cardiogenic shock patients, which means that all these patients are accepted in the emergency room by an intensive care medical team from cardiology together with an anesthesiology team, and these patients get a rapid focal screening with a transthoracic echo to identify impaired LV function or mechanical complications, and that by a standard, all patients in shock go to the cath lab irrespective of any ECG changes. And if they are in profound shock, they receive the hemodynamic support system, which on default is Impella. But if there is a biventricular failure or it's an ECPR situation, then they receive the ECMO. And we try to implant the Impella prior to intubations if the patients come in on spontaneous ventilations, and then we do a CAF in all these patients, and they have a dedicated protocol of how they were handled on the ICU. So there's a very strict protocol in the background to identify patients early and take them to the cath lab. That was the first message. The second is something also that we put together in an even larger European working group, of which many members are present in the room. It's a concept that was put forward by Patrick Hunziker several years ago at the EuroPCR, that if there is a severe reduction in cardiac output, we have to use a golden hour of shock to reverse the reduction in mean arterial pressures in coronary perfusion and end organ perfusion. And obviously the ideal way to intervene is not to use vasopressors, because that will further limit coronary perfusion and end organ perfusion, but to reverse it by unloading the heart. And we shouldn't wait to the parts when the ischemia, multi-organ dysfunction, and organ failure already starting or definitely established. If we are in the plaque phase, then it's actually too late to intervene by just reversing or improving cardiac function. Now, we try to hit very early, and that is what we showed in this clinical pathway before. Now, coming to the data, earlier this year we published first experience from the Hannover Cardiac Unloading Registry, focusing at that time on patients supported with an Impella CP for ischemic or non-ischemic cardiogenic shock, and only focusing on the patients with a single ventricular support. So no combinations with RP, no combinations with ECMO. And the 2 findings, first on the left, were that we can have a reasonably fair survival with low mortality, obviously, in patients that have more or less a normalization of lactate levels within the first 4 hours. We're talking about biomarkers, and starting at the emergency room, it's obviously difficult to anticipate how the reduction of lactate will be in 4 hours, but this was even better predicted than the lactate at baseline. And the other thing you can see on the right side is that patients that survive tend to have a severe reduction of inotropic exposition using the inotropic equivalent. So we can support these patients, and we can reduce vasopressors inotropes quite quickly, and that is related to mortality. So obviously this was a low number of patients still with 61, and if we try to compare what we know from best clinical data, and the best clinical data we have is a randomized controlled trial using the balloon pump in the IABP-Shock II study. You saw that the control group in the balloon pump didn't show a difference with a mortality of about 40% at 30 days. And the question is, what would happen if we treat these patients in real life with an Impella instead of a balloon pump or nothing? And you can see it on the bottom. If we go down in our registry, so we start with 250 Impellas up front, then we go to single ventricular CP 61, and we go to thus who fit the criteria from the IABP-Shock II trial, then we are down to 29 patients. Nevertheless, this low number of patients, if we put them into this graph, which is slightly unscientific, I must admit, we can see that the mortality seems to be much lower using a standardized protocol, using state-of-the-art devices, and using them quite quickly. Now, knowing that this is still a very low number, we tried to improve the data sample quality, and that's the reason why we started to collect data from 4 sites, and we wanted to compare the mortalities that we can achieve, since we do not have a control group, with predicted mortality, and we use 2 of the scoring systems quite available at the moment. One is a CardShock, and the other is the IABP-Shock II score. The CardShock score is derived in a cohort that consists of about 80% ACS patients, have 28% cardiac arrest, which is a little bit less than in the IABP-Shock II system, and has a mean follow-up of 12 days. In our initial experience with the 61 patients on Impella CP on the right-hand side, you can see that the CardShock score somehow is useful to distinguish based on the risk between survivors and non-survivors. On the other hand, the IABP-Shock II score, which someone would assume to be more relevant for our AMI cardiogenic shock cohort, and it's completely derived from shock patients, from AMI patients, 50% treated with a balloon pump, 44% with cardiac arrest, had a 30-day mortality of 41%. There are several questions. First, in our experience with the Impella CP, this score was not really helpful to distinguish between survivors and non-survivors. And second, if we look at the score variables, it's rather unlikely to get the patient into highest risk prediction if the patient didn't have a stroke in the history or you are unsuccessful in revascularizing the patient. So if the patient is completely revascularized in the culprit lesion and didn't have a stroke before, you need all the other factors to be present to have a high risk, and that will be relevant for the interpretation of results later. Now, when we look at our patients, the sample size from these 4 centers, from Düsseldorf, Hannover, Bonn, and Odense, was 166 patients that all fulfilled all inclusion criteria of the IABP-Shock II trial without any exclusion criteria. Now, obviously, one could say our patients were slightly younger than the ones in the trial, but our patients had much higher admission lactate levels, and they had a much lower LVEF in the echo that was done. So at least they seem to be, in my opinion, at least comparable, if not even a bit sicker. If we look at the overall data, the one thing we can focus on is CardShock. It's in the dashed lines because CardShock didn't use 30-day or in-hospital outcome. They used a median of 12-day follow-up. So we had to calculate the mortality rate at 12 days in our Impella cohort as well. And it was by percentage points, 10 percentage points lower in the patients treated with an Impella compared to the predicted mortality. So all the scores were calculated individually for every single patient. And secondly, using the IABP-Shock II score, there was also a similar difference at the 30-day mortality follow-up. In the middle, you see the prediction by the SAFE score, which is on veno-arterial ECMO, which is much higher in the AMI cardiogenic shock cohort. Now, going to the 2 scores that I introduced, the IABP-Shock score on the left and the CardShock score on the right, you can see it's the patients that are identified by the scores as being at the highest predicted risk of mortality that seem to profit significantly from being treated with the Impella. Now, we wanted to get a little bit closer in identifying patients potentially for treatment, and we tried to combine the IABP-Shock score and the CardShock score. So on the right-hand side, you see the overall cohort, and on left to it, it's the survivors and these patients divided. Now, what you can see on the x-axis is the IABP-Shock score, low, intermediate, high, and the CardShock score on the z-axis with low, intermediate, and high. And these are the absolute numbers of patients. What I want to point out is that the scores are not really concordant. This is a problem by interpreting the data. The majority of patients were medium to high risk in the CardShock score, but at the same time low to intermediate risk with the IABP-Shock score. And it is probably mostly to the fact that we had a quite good success in revascularization and very few patients with previous history of stroke. Now, if we want to look at mortality, the ideal model is shown on the left side. That would be kind of incremental, increasing mortality by incremental risk, being highest if a patient would be categorized at high risk by both scores, and a little bit lower if intermediate in one and high in the other score. And though this is certainly only for visual interpretation. And on the right-hand side, you can see the actual achieved mortality on patients treated with the Impella. The first thing that we can see in the patients deemed at high predicted risk by CardShock score is that we do not see additional effect by scoring with the IABP-Shock score, but the patients are at a certain level, and you had already seen that they were lower than predicted with mortality. Using the IABP-Shock score, patients with a median risk by CardShock score identifies one patient cohort with a certain higher amount of risks as the ones that are at the same time at intermediate risk in the IABP-Shock score. These three areas are shown separately because we had very few patients in these categories of low or intermediate CardShock and high risk for IABP-Shock score, so we cannot really interpret this mortality data. Now, the other findings of our analysis were two confirmatory results. The one confirmatory to what we observed in the smaller cohort in Hannover before, that having a patient with prior resuscitation harbors a much higher risk for mortality. And this is something very important if we try to do prospective trials and want to assess the efficacy of a device in cardiogenic shock. And that's the reason why I think Jacob is absolutely right that you put it forward in the DanShock and our Danger Shock trial not to include resuscitated patients if you want to assess the effect of the Impella in cardiogenic shock. And the second thing is confirmative to the data shown by Beal O'Neill's group here in the US, that we see on a second continent different system the same effect, that the mortality is much lower in AMI cardiogenic shock if we implant Impella prior to PCI instead of post-PCI. Now, my key messages would be that the AMI cardiogenic shock is a growing clinical challenge still in daily practice, and we have more and more patients coming with these problems. The conventional therapeutic approaches using inotropic support or with or without balloon pump have not improved the outcomes. In contrast, we have seen today that inotropic support might be disadvantaged. And if AMI cardiogenic shock is treated early and effective, LV is unloaded, catecholamines are weaned, and coronaries are completely revascularized, the mortality will probably decline. And in the absence of prospective trials, we need to use the retrospective analysis and to encourage people to use Impella in the proper patients. And confirmatory of this hypothesis is that the patients at highest predicted risk seem to have the best benefit in our analysis of these 4 centers. And thereby, thank you very much for your attention.
Yeah, Andreas, thank you very much for these interesting data. Of course, as you mentioned in your last slide, prospective trials would be desirable. What's the major hurdle to do the prospective trials?
I think if you do the trials really properly, and that is what the design from the Danish trial absolutely is about, is takes the right patient, severe AMI cardiogenic shock, no confounding errors by resuscitated patients. We see a lot of the differences in the excess mortality and culprit shock being derived or due to anoxic brain damage, so clearly independent from the shock itself or revascularization. This is the important thing, have the proper patients, and if we focus on the proper patients, the recruitment is very, very rare, and this is the reason why we have to get as many good centers that are very, very experienced with these devices and interventions to do the trial together.
Mm-hmm. Okay, other questions from the floor? This doesn't seem to be the case, so thank you very much. We're a little bit behind in time anyway. Thank you, Andreas.